Good evening. My presentation will be on colorectal cancer screening. I will talk about the rationale of screening and I will highlight the latest screening updates. As you know, March is the Colon Cancer Awareness Month, and in this occasion we are doing this webinar. So I'll start with the definition of screening. Screening is the application of diagnostic tests or procedures to asymptomatic people. This is very important. So we are not talking about patients who are presenting with symptoms, we are talking about asymptomatic people for the purpose of dividing them into two groups. Those who have a condition that would benefit from early intervention and those who do not. So we simply reassure them. A very important question would come to our mind. There are numerous types of cancers, and usually we do not screen for every single type of cancer. It's well known that we screen for breast cancer, we screen for colon cancer. So why is this discrepancy? Of course, you can see that colon cancer, breast cancer are one of the most common, but there are additional factors for which we screen for a certain cancer, and I will talk about this. First of all, we have to consider the benefit versus the harm for the patient, and we will tackle this soon after, and the impact on public health, where cancer should have a significant impact on public health to consider screening for this type of cancer. We need to consider the effect on financial resources, the patient wish, and most importantly, the outcome. So if an improved outcome cannot be demonstrated, the rationale for screening is actually lost. There are some ethical issues embedded within concepts of screening. Usually in ordinary medical practice, in our daily practice, the patient initiates an encounter because of a troubling symptom. However, in screening, the test is usually initiated by the physician. So there is some sort of implied promise about the effective intervention and doing no harm, which is one of the earliest and main principles in medical ethics. So what happens if a result is falsely positive? It will lead to unnecessary workup. It will lead to patient anxiety. Imagine someone who has a positive result and he is concerned that he might has cancer. It's not easy at all, and it will lead to unnecessary expenses. Whereas the false negative result would lead to false reassurance and would lead to neglecting important symptoms. So to think of an ideal screening program in general, we need to think of three main items: the features of the disease, the features of the test, and the features of the screen population. The disease should have a significant impact on public health and an asymptomatic period during which detection is possible, and an outcome that is improved by treatment during this asymptomatic period. The test that we are using should be sufficiently sensitive and specific to minimize false positive and false negative. And of course, the screen population, we need to have a sufficiently high prevalence of the disease to justify the screening and relevant accessible medical care. So you can see in this graph the natural history of a disease. The disease passes through a phase where it's not detectable at all. After that, you can see here time t0, after which the disease becomes detectable using a test. Then comes T1, after which the disease would be clinically detectable. This concept is very important to illustrate the feasibility of screening. In a way, there is what we call a critical point in the course of a disease. What is a critical point? A critical point is a point in the natural history of a disease before which the therapy is relatively effective, and after which therapy is relatively ineffective. So in case of cancer, usually the critical point is the time at which regional or distance metastasis occurs. So whether a screening test would be effective or not depends on whether the critical point occurs before, during, or after the asymptomatic period, having detectable preclinical phase. So you can see here, you can see the onset of a disease, the point where the disease becomes detectable by a test, the point where the disease develops signs or symptoms, and the point where death would occur from this disease. So if the critical point lies here, then the screening would be effective. However, if the critical point comes before the disease becomes detectable by a test, then it's nonsense to screen. And if the critical point occurs after the signs or symptoms develop, also it's nonsense to screen, because by this point we can detect the disease by the occurrence of symptoms. So it's nonsense to apply screening test. These concepts are very important for us to know and appreciate the importance of guidelines. These current guidelines take into consideration these factors, so that there are guidelines to support the screening of certain cancers that we need to abide by. So talking about colon cancer is the third leading cause of cancer death for both men and women, and it's most frequently diagnosed among persons aged 65 to 74 years. It's estimated that only 10% of new colorectal cancer cases occur in persons younger than 50 years. You can see here the recommendation summary of US Preventive Services Task Force. First of all, the old recommendation that states that adults aged between 50 and 75 years of age need to be screened. This still applies with a high grade of evidence, grade A evidence, that all adults need to be screened. And recently, adults aging between 45 and 49 are included in the population to screen for colon cancer. Adults aging between 76 to 85, there are more or less different recommendations. However, many guidelines focus on the quality of life and how much the patients are well preserved to consider screening or not in this age group. So in general, we screen adults 45 years and older who do not have signs or symptoms of colorectal cancer and who are at average risk for colorectal cancer, because those who have higher risk can be screened earlier. So as I mentioned earlier, the US Preventive Services Task Force expanded the recommended ages for colorectal cancer screening to 45 to 75 years of age. And they recommended selectively screening adults aged 76 to 85 years for colorectal cancer, but not beyond 85 years at all, by all guidelines. How do we screen for colon cancer? The screening strategies, we have more than one strategy to screen. We can use the high sensitivity gouache fecal occult blood test or fecal immunochemical test every year, or we can use the stool DNA FIT every 1 to 3 years, computed tomography colonography every 5 years, or flexible sigmoidoscopy every 5 years, flexible sigmoidoscopy every 10 years with annual FIT, or colonoscopy screening every 10 years, which remains the gold standard of screening. So how would you choose the screening strategy? Clinicians and patients may consider a variety of factors in deciding which test may be best for each person, depending on the frequency of screening, location of screening, method, pre-procedure bowel preparation, anesthesia, and follow-up procedures for abnormal findings. What about other guidelines? Many other organizations have issued guidelines on screening for colorectal cancer, and there is general consensus that average risk adults aged 50 to 75 years should be screened. This consensus comes from most of the societies that have guidelines for colorectal cancer screening. The American Academy of Family Physicians, American College of Physicians, American Cancer Society, and the US Multi-Society Task Force are recommended routine colorectal cancer screening in this age group, although specific recommended tests and frequency of screening may vary. Currently, where recommendations and guidelines vary is the age of to initiate screening. So in 2017, the US Multi-Society Task Force recommended beginning screening at age of 45 in Black adults and screening at age 40 years or 10 years before the age of diagnosis of any family member, whichever comes earlier. In 2018, the American Cancer Society recommended that screening begin at age of 45 years in all adults. The American Association of Family Physicians does not address screening before the age of 50 yet. In 2021, the American College of Gastroenterology suggested screening in average risk persons aged 45 to 49 and recommended screening average risk persons between 50 and 75 years of age. Generally, guidelines all agree that screening should either be individualized in older adults aged 76 to 85 or stopped altogether, with a clear consensus that screening should stop after age of 85 years. Finally, patients who have familial adenomatous polyposis, the first degree individuals at risk for FAP include the first degree relatives and individuals with more than 10 cumulative colorectal adenomas or colorectal adenomas in combination with extracolonic features associated with FAP, like duodenal ambulatory adenomas, desmoid tumors, papillary thyroid cancer, congenital hypertrophy of the retinal pigment epithelium, epidermal cyst, or osteomas. Thank you.